All right, it's 12:01, so I think I'm going to go ahead and get started, and others who are joining can follow along. So welcome everybody to today's webinar. Really pleased to be joined today with Josh Dugas from San Bernardino County, Heather Reedhead from California Department of Public Health, Sarah Sacco from Contra Costa Health Services, as well as the California Association of Communicable Disease Controllers, and Shadi Barfjani from San Joaquin County. A little bit of housekeeping today. All lines are muted. You may submit a question at any time through the Q&A box at the bottom of your screen. And this session will be recorded, so it's going to be available afterwards. One of the things I do want to mention is that I'm happy to have CDPH and CACDC here, as today is not only one of the lecture series for Manifest MedEx educational webinars, but it also serves as one of the Lunch and Learn series for CACDC, CDPH, and I'm going to get this right, the California Conference of Local Health Data Managers and Epidemiologists. So thanks to all of you for this joint effort today. So a little bit about who we are at MX. Manifest MedEx is one of several independent nonprofit health information organizations that work together to serve all of California. The Manifest MedEx HIO, or Health Information Organization, serves a lot of Californians. We have more than 32 million health records on Californians across a dozen plans, more than 125 hospitals, and over 1,800 providers. So our mission is to provide every healthcare organization in California with the information they need to improve care, enhance health, and lower costs. And one of the ways that we do that is as a member of the California Association of Health Information Exchanges. So together with our HIO partners across California, we're focused on making sure that together we facilitate and promote the secure sharing of health information across the entire state. Before we dive into hearing from our guests, I did want to talk about a few key points. And one of them is that it's become clear to all of us who do this work that data is essential public health infrastructure. We've learned a lot of lessons from the COVID-19 pandemic about the gap in data that we have between public health and clinical care. And throughout the pandemic, we did a lot of innovative things in a short amount of time to fill those gaps. But it's really been like, glue and safety pins and everything. And now we have a real opportunity to take a look at how data can be used across the entire system in California to deliver equitable and effective public health services. Now, health information exchanges have played a really, really important role in providing healthcare interoperability for a long time, kind of behind the scenes. But now with what we know from the pandemic and kind of this moment in time that's calling to us, we also know that we have an obligation to close these infrastructure and systems gaps between the healthcare ecosystem, government health and human services, as well as the communities that we all serve together. So today, California is doing some amazing things. It has this goal of California for all, and part of that California for all is a healthy California for all. All means everybody. It means nobody gets left behind. And part of the way our state is going to achieve that is through a data exchange framework that also includes a single data sharing agreement that almost every healthcare entity has got to sign by 2024. And it also is making incredible investments in a CalAIM effort that relies on the exchange of health information. So a little bit of level setting on what health information exchange is and does. You can read for yourself the terminology on the left, because one of the things that we found is not everybody uses the same words that we do. But I want to call your attention to the graphic on the right. And this is just about health information exchange. Health information organizations exchange, they're an intermediary. And there's this growing national trend towards the idea of a health data utility model, where there's this statewide uniform model of data sharing, one that California is pursuing, that combines, enhances, and exchanges electronic health information across this entire ecosystem. And there are, missing folks on this graphic. But to really facilitate having the right data at the right time across the entire system. The way I like to look at this is thinking of health information organizations as the health data safety net. So we all know that equity is a huge issue in terms of health outcomes, not only in California, but for the nation and the world. And when you look through an equity lens, what we know from the last decade or so is that very large health systems and very well resourced organizations have the ability to do this. But the safety net, whether it's county health and human services or FQHCs, small practices, independent providers, have been left behind. So the role of HIOs today in California is that we all work together to serve as this health data safety net. We're really, really crucial in leveling the data exchange playing field across all of these partners, not only the ones that have the resources to participate well. So really, it's an exciting time in California to put the weight of its vision and in investments to really utilize data in that true health data utility model. So today we're here to talk about one particular use case, and that's the use case of health information exchange to address congenital syphilis. Why congenital syphilis? I've worked in public health a really long time, and in the beginning of my public health career, we really thought that congenital syphilis was something that was close to being eradicated. And here we are 25 years later, where we're nowhere near that vision that we had so many years ago. You can see on the graph on the right that the number of babies born with congenital syphilis has increased for the 7th year in a row. And between 2012 and 2019, it's been an increase of over 1,200%. It's like mouth gaping numbers for me. And the increasing rates are most notable in Southern California and in the Central Valley. Congenital syphilis obviously disproportionately impacts, like many other diseases, certain populations. So health information exchange. This is a use case in which health information organizations have worked with local health jurisdictions, 2 of which are here joining us today, to really take a look at how we can change the way we identify, intervene, and treat disease using health information exchange in an innovative kind of way. So this is huge for me as a public health professional, because we all know that racism, stigma in medical care, poverty, transportation, all of these things are factors that make it so hard to address a public health challenge like syphilis and many other public health challenges. So HIEs can serve as that health data utility that I spoke about by sharing information across all of these teams, from hospitals to public health communicable disease units to providers. And we can play a really, really important role in terms of finding folks who otherwise would be lost to care. So today we're really pleased to have our partners from not only counties, but CDPH here, and looking forward to the conversation. I'm going to go ahead and turn it over to Sarah Sacco from Contra Costa County.
Thanks, Mimi. Just again, wanted to welcome back our California local health jurisdictions and CDPH. We partnered with Manifest MedEx to bring you the 2nd session of our learning series, which partners up with their session. And as Mimi mentioned, it's co-hosted by the California Association of Communicable Disease Controllers, which I represent, and the California Conference of Local Health Data Managers and Epidemiologists, and California Department of Public Health, or CDPH. Our kickoff session was a success. We actually had over 350 participants from state and local public health across California. We discussed a few potential public health use cases for HIEs, ranging from COVID response, heat illness, and then dove in briefly to congenital syphilis. But we are excited today to hear from those 2 local health departments mentioned before, San Bernardino and San Joaquin, on how they have already utilized ADT messages and notifications through Manifest MedEx to improve public health disease investigation, care coordination, treatment, and to overall avoid preventable adverse outcomes. So for those in public health, or those not in public health, let me just like kind of set the stage of where we in public health are. At the beginning of COVID, many of us in the local jurisdictions quickly realized and experienced the lack of real-time access to digital health record information. Our telephones and confidential fax machines were bursting at the seams as providers were manually reporting health information that we knew already existed in electronic health record systems to public health. And so then in 2021, as Mimi mentioned, we were excited to see the passage of Assembly Bill 133, which was to develop the data exchange framework. So that is kind of when this discussion began amongst local jurisdictions and the state public health to try to identify public health use cases. And so that's where this group was assembled as a committee to basically bring an educational forum to the topic and also have LHJs share success stories across both EHR and HIE access issues. So without further ado, I'll pass it off to Dr. Heather Reedhead, and she's going to step into a few of further basically understanding the changing landscape within public health, along with some general public health use cases. Thanks.
Thanks, Sarah. So this is an exciting time, and Mimi actually already referenced, I think probably the biggest thing was COVID, right? That really has galvanized all of this movement and consolidated, I think, a lot of our thinking about where we need to go forward in terms of data exchange. And what I really wanted to call attention to in this slide is that there is a lot of alignment right now, which is very helpful for public jurisdictions, both at the federal level with CDC, the Public Health Informatics Roadmap and the Data Modernization Initiative, and then also at the state level with our California AB 133 and the agency level work, CHHS level work on the data exchange framework. That are all telling us at the same time that we are expected to have interoperability between healthcare, public health, and then also ideally social services. And really, I think agency has focused a lot on the individual care of the high-risk patient, again, that Mimi referenced before, really trying to focus in on health equity and bringing together all of those data streams that are caring for that same patient across different offices, different state and local departments. Specifically in that agency work in the data exchange framework, they have come up already with a data sharing agreement. It's now in the phase of being revised, but we actually do have a state level data sharing agreement that's on the table for both, again, healthcare, public health, and social services to be engaged with. And they are also taking on in a very detailed way, the digital identity work, so that we can actually appropriately match people across these settings, so that we know that if we are trying to bring together data elements from healthcare and from housing or in public health, that we are in fact correctly identifying the right person and bringing in the right information at the right time. And then lastly, again, that there is actually also alignment with the patient expectations and public expectations. In 2020, I think people really thought that we were more advanced, that we had better data interoperability than we had. But at any rate, in 2022, we're going to take that on and we're going to tackle that. And we're going to make sure that, in fact, we're meeting that public expectation and patient expectation, so that when we are collecting data, that we're not asking for it in 4 different settings, right? That we can actually leverage data that's been collected in other places. And so when different providers or in public health and a primary care provider are talking about the same patient, that in fact we are seeing some of that same data, so that patient is getting the absolute best care that they can get at that moment, regardless of whether they are being seen in a public health clinic, a federally qualified health center, or a major hospital system, that we are really equalizing that and bringing all that data together. So again, just highlighting that there is alignment at this time. And we'll go ahead and go to the next slide. And then, oh, this doesn't look so good on my screen. Hopefully it looks a little better on your screen. But what I was trying to show here is that it's important to think about how we use the data and all of the breadth of the public health use cases that many people are unfamiliar with. So like me as a physician, I'm a family physician by training. And when I am in my public health department role, I am often clinically managing patients. I am doing that top level over there. I'm working with the individual level data. I'm providing clinical care, clinical consultation, directly managing the patient, or I'm weighing in on that second line, which is still patient level information on case management, whether that's a tuberculosis patient or syphilis patient or whatever condition that I'm dealing with. The bottom half of the slide, though, is other unique roles that public health plays, like outbreak management. And in outbreak management, even more so, I am in charge of all of the clinical care of a group of patients, maybe that's living in a homeless shelter, or that's in a jail, or another facility that doesn't have a doctor on site, or another provider on site. And so again, I'm really in real time having to manage their testing, vaccinations, their medications. And I need all of that direct, clinical data, just as I would if I was over in my primary care clinic. And so this slide again is meant to like really open people's eyes and recognize the breadth of what public health departments do. All of that epi and analysis work is definitely important, but it's not all of what we do. We have very clinical roles that require real-time access to clinical data in order to do the best job that we can. And we're often taking care of the most vulnerable patients, right? And those folks that have the least access to healthcare. So I'll leave that. This is really a reference slide. I want to make sure we have plenty of time to talk about our use cases. So let me go ahead and advance the slide. And I think that I'm handing it off to Josh Dugas with San Bernardino County.
Thank you very much. Good afternoon, everyone. You can go to the next slide, please. My name is Josh Dugas, and I am from San Bernardino County. For those of you who aren't familiar with us, we're the largest geographic county in the contiguous United States. We have a population a little over 2.1 million, so we're pretty big. And if you're familiar with the Healthy Places Index, we have a large portion of our county that falls in that lowest quartile. So we definitely have people that are underserved and in need of help. So there's no lack of work for us here either in that regard. So next slide, please. I'm not going to spend too much time going into this. I think Mimi did an excellent job of breaking down what Manifest MedEx is, but we use two different tools from Manifest MedEx. We use a tool that is access that allows us access to records and information. And then we also use the Notify tool, which sends real-time notifications to us. And that's what we're going to primarily focus on during this presentation. Next slide, please. So what's the challenge? I think it was mentioned earlier, but congenital syphilis, they're on the rise. I will say on these numbers that though it went down in 2021, I don't think that's accurate in the grand scheme of things. It may have been a slight dip. It may have been data reporting that didn't come through correctly, but we're not seeing a decrease. And I don't want that to be misleading that we have somehow improved. But you can see our numbers are very similar to the rest of Southern California and other areas throughout the state and country, and that we are seeing an increase in something that like I said earlier, should be eliminated and is obviously preventable. So it's very concerning for us. Next slide, please. Where a lot of this challenge comes in is that the population many times we're trying to support and help here are very, very difficult to continue to interact with. Limited no prenatal care, drug use, mental health disorder, homeless, unstable housing. You can see there's some other things on here. It's usually not a simple, not that syphilis is simple, but there are usually other underlying or additional health concerns associated with many of the individuals we interact with. And they're hard to find. Once they're out of we're out of communication with them, it's very, very hard to track them down again and to provide them the care. We spend a lot of resources guessing and trying to call our birthing hospitals and looking for people and hoping to identify them and catch them at the right time and notifying the staff on board to be able to provide the services. And a couple extreme but very challenging situations is once the children are born, we had one case that was the child was adopted, and that's wonderful, but they went into foster care in
in a different state and trying to work through the bureaucracy and challenges of finding out where this child was, getting a hold of a contact and getting this child into treatment. It cost us very, very valuable time and lots of resources that, put this poor child at risk and, stopped us from being able to help other individuals while trying to find this person. So next slide, please. That's where our friends at Manifest MedEx come in. And like I said earlier, we utilize the notification tool. And whenever these individuals check into a hospital, whether it be for an emergency room visit or or to give birth, we're notified real time. And it allows us an opportunity to connect immediately and ensure that proper testing and treatment are provided to both the mother and the child in these situations. So it's a wonderful, wonderful tool. Next slide, please. This is a walkthrough. It seems almost too simple on here, but it's not much more complicated than this. You receive an email, we access the portal, we look up recent interaction, and we follow up with the provider. Now, there may be challenges associated with each of these steps, getting a hold of the provider and whatnot, but it really is this easy, and it makes our lives and the lives of the providers much easier, and more importantly, allows us to help these individuals that they definitely need it. So it's a wonderful tool, and it's been pretty successful for us. Here's some numbers you can see as we kind of work our way down, but the two I want to focus on are in the middle. Primarily, actually, the third one, you can see that of the 40 patients with encounters, we were able to follow up with 30 of them. That's amazing. That's 30 people we probably would not have had the opportunity to interact with. That's 30 people we would not have been able to help. Do we want those numbers to be closer to 108? Of course we do. But the fact that we were able to get that many and able to treat a large number of those was amazing. It's been successful, and it's only improving as we work through it and work out some of the kinks and find better ways to use it. Next slide, please. Some of the lessons learned. We were able to provide feedback to Manifest MedEx, and they were very receptive to our asks and needs and concerns, and it worked out wonderful. We learned very quickly that though we're focusing on congenital syphilis, this is going to offer a lot of opportunities for other diseases that that we can help use this tool to better provide service. And some of the challenges are just logistical, right? We're a health department, as many of you I'm sure we're open Monday through Friday traditionally. People don't always visit the emergency room Monday through Friday, 8 to 5. They can't always predict when they're going to give birth. They may come in on a weekend, and we're working through that, but there are some staffing challenges, and we're working through that with things like on-call people, and we're discussing a number of different things. But one of the definite lessons learned is that with a tool like this, not only can we get far better outcomes, it allows us to utilize our limited resources in a far better way, as opposed to trying to almost have a scavenger hunt, trying to figure out when and where and how to treat some of these people. Next slide, please. And these are some of the successes. I think I've referenced a lot of them, but the main success is that it allows us an opportunity to connect with people we may never have connected with again. It allows us to obviously treat not only the mothers, but give these children a better chance at a healthy and productive life, and treat and again address something that is 100% treatable and allows us the ability to lighten our workload while also being able to focus on additional needs throughout the department and other diseases that are oftentimes pushed to the side while we focus on these more severe cases. Next slide, please. Future expansion, I kind of mentioned that earlier, but TB, HIV, early syphilis, the opportunities are almost endless when it comes to many of the things we do. So we're very excited to continue streamlining what we are doing when it comes to congenital syphilis, but also expanding this into other areas and being able to help the public that needs us so dearly in many of these situations. Next slide, please. With that, I want to say thank you for the opportunity to present. Here's a case study that we worked on with Manifest MedEx if you want to read more about what we're doing here. And there's an email we have there. It's a general email, but we check it all the time. Please don't hesitate to reach out to us, and we'd love to partner with any of you and talk about it. We're very proud of what we've done. We want to thank Manifest MedEx again, and thank you for the opportunity. And with that, I will hand it over to, I believe, Dr. Barpan.
Thank you, Josh. Good afternoon, everybody. My name is Shadi Bafjani, and I'm a Senior Deputy Director with San Joaquin County Public Health Services. Next slide. I would like to continue the conversation by adding that a recent study by UC Davis published in Nature in June of 2022 shows that Central Valley's small to medium-sized counties have significantly higher rates of congenital syphilis when compared with larger metro areas. And the data that was studied, that was reviewed in this study was from 2019. Now, San Joaquin County is one of the medium-sized counties in the state of California with close to 1 million population. San Joaquin County in the study was identified as one of the 3 counties with the highest rate of congenital syphilis. To be exact, the rate was 297 cases per 100,000 live births. The study also observed a correlation between congenital syphilis rates and poverty rates in the state. And the poverty rate in the 3 counties identified in the study was also the highest in the state. The study also observed that the mothers of congenital syphilis cases typically have delayed or no prenatal care and are typically lost to follow-up due to reasons associated with poverty, such as housing insecurity and instability, high out-of-pocket cost of visits, and demands of their low-income employment. Next slide, please. Now, San Joaquin Public Health STD Control Group data also confirms that a significant number of female cases in reproductive age group with known and unknown stages of syphilis are commonly lost to follow-up. Public Health also identifies that the risk factors for being lost to follow-up or unable to attend their prenatal care is drug use, homelessness, history of incarceration, delayed or no prenatal care, as well as low health literacy. Additionally, one of our biggest challenges has been partner elicitation and services that has been extremely difficult to pinpoint, and it has caused less than optimized infection control in this age group. Next slide, please. So delayed access to prenatal care gets even more complicated by missed opportunities for screening and treatment in the emergency and correctional settings. Our most recent data shows that 29% of pregnant women who presented to the emergency departments were not tested in the ED. And of those who were tested and were positive, 45% did not initiate treatment in the emergency department. And in the correctional setting, this rate was about 33% for pregnant women who didn't get screened and treated for syphilis. Next slide, please. So considering the state of syphilis in San Joaquin County, Public Health Services set goals to improve identification and case coordination for pregnant mothers and infants, and improve case finding, education, and care coordination of male and female in reproductive age groups. And also improve referral to other county and community programs and services such as whole person care, MCAH, Black infant health, to address social determinants of health and to provide a more wholesome approach to care. Next slide. To reach these goals, Public Health Services in San Joaquin County employed a multifaceted approach to syphilis control starting in 2018 by initiating field testing and treatment, extensive provider detailing and education, promoting CDPH's expanded screening recommendations, establishing jail syphilis project for screening and treatment of reproductive age women and men, and most recently implementation of Manifest MedEx ADT notification system. Next slide, please. So this slide shows a summary of our data depicting that we have had the highest numbers of congenital syphilis cases in 2019. Our numbers have been going down. I cannot exactly say why, but we are thinking possibly as a result of the measures employed since late 2018. And at least we are hoping that this is an outcome of our of our efforts. Next slide, please. This slide again shows that we have a large number of females in the reproductive age group with known and unknown duration stages of syphilis that are lost to follow-up. And these numbers are from the last few years up to date, but nonetheless, our numbers are significant. Next slide, please. So as I mentioned, we most recently piloted the Manifest MedEx ADT notification system in the county, but before we launched the program, we had our local HIE already established between Department of Healthcare Services and 3 other local hospitals. And to set up the launch, we identified lost to follow-up incidents and created patient panels that were shared with Manifest MedEx. This panel is updated monthly. We created an email specifically to receive real-time notification when patients are admitted in the ED, inpatient care, and in labor and delivery. We also created standard operating procedures in collaboration with participating hospitals. We identified and trained nurses and communicable disease investigators to follow up with our cases when ADT notifications are received. My next few slides show a summary of our standard operating procedures that Josh touched upon, so I don't want to waste your time. So next slide, please. And so these are screenshots of when you log into Manifest MedEx database. Next slide, please. And so I have the SOPs in these couple of next slides. These are available to share with anybody who is interested in our operation. I'm happy to share. To address the after hours issues, we are working with our public health nurses who are typically covering the after hours. There are on-call nurses, standby nurses, and we have the standard operating procedures for them as well. Next slide, please. So our experience with Manifest MedEx is fairly new. The pilot went live on September 15, 2022. We had a few technical glitches, of course, but the team from Manifest MedEx has been extremely supportive and helpful trying to figure out how best to move forward. I would like to share a quick snapshot of our outcome. Since the start of the pilot, we've had 24 ADT notifications. Most of them were high emergency department utilizers, among them 2 reproductive age women. 1 got adequately treated, 1 was referred to a provider for further testing. She was lost to follow-up. We later were able to identify her again and bring her back to the public health department to provide treatment for her. 1 patient was over 50 and was discharged without treatment. The provider did not want to follow our recommendations. And 2 reproductive age males, 1 received test results and referred to treatment in a community health center, and 1 was lost to follow-up again. We are working in closing the gaps. So this is our pilot project. So we're hoping that all these small little barriers to care will be identified and addressed in the next few months. Now, one question that may come to mind could be the cost of Manifest MedEx participation and implementation. Participation through our local HIE for our local health jurisdiction is about $10,000 annually, but that's of course subject to change with possible revised rates from Manifest MedEx. Staffing costs are not significant as they're mostly existing staff who are funded either through our STD grants or general fund. And even though our costs have been not been extremely high, but we are hoping because of the potential cost saving for health plans due to LHJ efforts on treating reproductive age women and early detection and treatment of syphilis cases, that the health plans would step up and either fully cover the cost of LHJ participation in HIEs or heavily subsidize it. And that's just the hope. Next slide, please. So ADT notification system, in my humble opinion, has the potential to be used in other programs. We are currently using the system in our whole person care program, as well as our pilot for the syphilis, congenital syphilis, and STD control. And we are hoping to use Manifest MedEx access and notify system in the future for HIV care coordination and for lost to follow-up patients in our latent TB infection project. Well, thank you very much for allowing me to present our pilot project, and I'll pass it on to Mimi.
All right. Thank you so much, Shadi and Josh, as well as Sarah and Heather. There's been so much good work done in this space. And I hope that the work was going to be prompted regardless of whether we had a pandemic to prod us along. But we're living in, as I said before, this is really, there's momentum happening right now in our nation and in our state. And I feel fortunate to be working in a state that really is investing in and making a priority of data exchange. So I also have to, I would be remiss if I didn't thank Heather and Sarah also for the partnership, just the thought partnership in thinking more broadly about how the work can go beyond individual HIOs and individual local health jurisdictions, but really be addressed from a broader perspective across the whole public health system in California. We do have a few questions in the chat that hopefully our panelists will be willing to assist in answering. One question that I'd like to pose to the group is, especially for those, for San Joaquin and San Bernardino counties, is you glazed over a little bit about glitches and some barriers and challenges to getting started. San Joaquin is a little bit newer. They're in the phase of onboarding now, and then San Bernardino has the benefit of looking back over a little more than a year. So could you talk a little bit about the barriers to implementation and some of the things that might have been surprises for folks who may be interested in using this in launching this use case?
I can start if that's okay. I think some of the barriers that we had are similar to any new implementation of a new process, getting staff on board and ensuring, thankfully, this is an easy process, but anything different takes a little bit of time and effort to ensure that not only they're trained, but that they continue to use it. So there's a little bit of a challenge there. I think minor tweaks in how our systems and how we interact and how Manifest MedEx function were necessary. And that, again, it wasn't difficult. It was just something that needs to be considered. And I think the other challenge is ensuring that you have enough participants throughout the region, different clinics and hospitals participating to make the initiative valuable. We're very fortunate that we have a lot of partners who are using Manifest MedEx. There's a couple larger systems, or at least one I know of, that we hope will begin using it soon. But I think one of the limiting factors is not necessarily something that's within the LHJ's control, but something that could be addressed and provide even more benefits. So I don't think for us there was any steep or large barriers, but very standard and traditional barriers that I think can be worked through with a little bit of trial and error.
Thanks, Josh. Shadi, do you have anything to share in this space?
Sure. We were lucky because our county had an established relationship with Manifest MedEx through a local HIE before we started our pilot program. But it took us a little bit to build our databases and our incident panels to be communicated with Manifest MedEx. And we experienced a little bit of a technology glitch when we went live, where we couldn't access the notifications in real time. As a result, we were about 2 weeks delayed. And so once we got the notifications, we still were able to reach out to the patients, because what happens with those notifications is that because of the admissions in the ED or in the inpatient departments, the patient information is updated. And so it gives us, puts us in a better situation, even if it's not a real-time situation, to get in touch with the patient and to follow through with the patients as far as their treatment will go. So that challenge has been removed so far, and our system is operating very smoothly. As Josh mentioned, some of the challenges are with larger health systems that operate in our geographic areas. We only have 3 major hospitals now that are participating with our local HIE. And it could be better if there are more participating hospitals within this space. But even with our 3 hospitals, I think the experience is looking very effective, even in the past 6 weeks.
Thanks. So that makes me think there are a few questions that are really about how do the systems work together? How does the reporting happen? How do you get information from EMR? So maybe I'll take a stab at kind of painting the picture, is that if you think of the ecosystem of who is sharing data, the local health jurisdictions cannot get an alert from a hospital that's not participating. So if you've got large health systems, or if you've got hospitals that are not also participating with your health information organization, the universe of who you get alerts on is limited. It's part of the reason why the use of health information exchange is really about partnership and collaboration. It allows a public health solution to public health problems. And so, you know, as counties are thinking about the potential of partnering with ourselves or their health information organizations to launch something like this, which really is being able to find a patient lost to follow-up for any potential complex care coordination issue at this time related to communicable diseases, just because of policy issues, then I think it's important to note that all those folks in that ecosystem, we all have like a shared responsibility to say, participate. So participation, there's another question that's been posed. Why aren't tribal health entities included in the graphic earlier in our presentation? That is not an exclusive or an inclusive graphic. It's just an example. Actually, any part of the healthcare system that wishes to participate can. The way it works is health information organizations are not public entities. They're a network of private nonprofits. And, you know, they all have costs to cover. They all have different capacities. And so it really is up to individual entities in the provider systems, the FQHC systems, the county systems to say, we're going to participate. And those who don't participate aren't kind of participating in that data sharing ecosystem. So I hope that's kind of helped answer some of those questions that we've seen coming through in the chat.
Mimi, could I ask that there's another question in the chat from a CDPH participant that I think it would also be helpful to hear, like, what data elements are coming across to the local public health jurisdiction. So if Dr. Barfjani or Josh wants to answer that in terms of what can they see, or what does that nurse see on the screen when they do get that notification?
Sure.
Dr. Barfjani, I'll let you go first on this one.
So once so our system is set up where we get the notification in a specific email. So we log in through the link provided in the email and get into the Manifest MedEx database. And on the Manifest MedEx database, we are able to see the admission information, the hours, and some general information about the demographics of the patient. And then we use that information to enter into CalReady to look at the history of the patient when it comes to the syphilis screening and treatment and case identification. And then we will call the hospital charge nurse and the supervisor, house supervisor, to share that information and provide the next steps that are appropriate for the care of the patient. Now, we would like to see more details of the longitudinal health information. It has not been available to us through the syphilis pilot. We have the access through our whole person care, but this has not established yet, and I guess there has been some legal challenges for getting access to the longitudinal health information through Manifest MedEx. However, the county has separate agreements with these healthcare systems, and so it will give us the capability to log back into the EHR systems and actually review the longitudinal data of the patients. If these two systems could become combined at any time in the future, it just will be much more facilitated and much easier for our nurse or the communicable disease investigators to see everything in one place. But even without that, I think the system is still very, very effective in helping us identify the lost to follow-up patients.
And I can follow up a little bit with what Dr. Bafjani has been discussing. And so, you know, the way there's a huge policy opportunity and also policy challenge to the work in public health. And so San Bernardino County, for this particular use case, has been using MX Notify, which is the ADT, the Admit Discharge Transfer Alert, as well as access to the longitudinal record. And so San Joaquin County has been wanting to do, you know, also have access to the patient longitudinal record. So what that requires from our behalf as a health information organization is an amendment to the participation agreement. There's some work that we're going to have to do, but there's actually conversations that we've had with CDPH on a broader perspective, because this challenge exists across many counties, it exists with the state public health department. I've worked for counties for many years, and while we all want to do the right thing in sharing data so that we can improve health, the complex web of statutes and laws and legal opinions around what data can be shared and cannot be shared is often a barrier. So there's actually a lot of work being done in this space. And one of the things that seems clear that I hope that some work between health information organizations, local health jurisdictions, and the state public health department will kind of shed light on over the coming months is the fact that there is statute that clearly points out what information is shareable, and that we can work together as systems to provide some authoritative guidance so that we don't have these kind of challenges through county council or general councils on moving forward with what we know is going to be really helpful in these kinds of use cases. Okay, I don't know if you have something to add to that, Josh.
No, I was just going to say, I think you did an excellent job of covering that.
Okay. Okay, you look like you were ready to say something. But my own experience, I see some heads nodding with my colleagues around the room, and it's definitely an area that we're all working on right now. So I know that there are many more questions in the chat. I hope that we'll be able to get back to participants after the webinar, and we will be saving those questions so that we can get back to everyone in a timely manner. In the spirit of collaboration and hearing the work that San Bernardino County and San Joaquin County have done, and also hearing a little bit about just the magnitude and also the, for lack of a better word, momentum of the rise of congenital syphilis in California. One of the things that we'd really be interested in doing, and by the we, I say Manifest MedEx as a health information organization and our counties that have already started work in this area, is when you look at who is impacted by congenital syphilis and the rise of this in California, while it's clear, it's concentrated in certain areas, counties in the Central Valley and Southern California, counties that have high poverty rates and other social determinants of health that make tackling this in the traditional ways really, really difficult. So what we are doing is we hope to really kind of jumpstart the work on this and form a cohort of interested partners from local health jurisdictions and their partner health information organizations. So if you are a local health jurisdiction that is experiencing extremely high rates of syphilis and are interested in working together with a cohort of health information organizations and counties to figure out how do you launch a use case like this, and in the future and in the very near future, as you start piloting, as you've heard from San Joaquin and San Bernardino counties, be able to have some peer-to-peer learning and network and share best practices and other lessons learned, so that together we can have as much of an impact as we can in learning about this use case to combat congenital syphilis. So in that vein, we are working, there are 2 work group meetings that will be held for counties and their health information organizations interested in learning more about what resources does it take, the workflows, and really the time and energy to implement this kind of model. And these work groups will be held November 16th and December 7th from 2 to 3:30 p.m. The outcome that we hope to achieve is that there will be this formal collaborative of counties and HIOs that decide to join hands and participate in this peer-to-peer learning collaborative. We have Manifest MedEx is interested in hosting this work, although we don't want to own it. We just want to be a partner, just like any of the other peer partners in this group. And for the time being, we have Intrepid Ascent, which is a strategic consulting firm, which has made themselves available through the end of the year to facilitate, convene, and put together the materials for these 2 work group sessions. So if you're interested in learning more, please contact myself or Alex Horowitz from Intrepid Ascent. Our contact information is there, and we already have counties interested in joining, but I think that if we really got like the top 10 counties or even the top 5 counties in terms of rates or cases in California together, we would make an amazing impact on congenital syphilis. And then that's my pitch. So I'm going to go ahead and turn it over to CACDC and CDPH for their pitch for their learning collaborative.
Thanks, Mimi. So just a reminder, today was our session 2. We have 4 more sessions that will be held Wednesdays at noon. They're listed here. We're going to dive into some like 101 more details on how this all works, some myth busting on what we can and can't do, and some other activities. So we look forward to having you all. That we will be back in our normal team session going forward. Thank you.
Okay, with that, thank you for this afternoon, this hour of collaboration over the lunch hour today. Really, really appreciate the partnership, not only from our state and county partners, but as well as our MX participating counties. Our next webinar for Manifest MedEx educational series will be Thursday, December 1st from 12 to 12:45. And we'll have our Chief Information Officer, Jason Buckner, and our Director of Health Policy, Felix Su, provide an overview of the data exchange framework, the data sharing agreement, and the requirements under AB 133. So we hope that those of you interested in learning more will be able to join us then. And thanks so much to everybody for taking the time to both participate and to speak today.